Hello, it's Dmitry again. Today we'll be going back to the Mehlman medical textbook, looking at the internal medicine PDF, I should say, for Mehlman Medical. We'll be going back to the gastroenterology section today and wrapping up, hopefully. We're on page 136, so we'll be wrapping up on page 148. Again, this is the gastroenterology section of the internal medicine PDF for Mehlman Medical. So, let's begin. Viral hepatitis. Two foundational points you need to know. Hep A and E cause acute hepatitis only. Hep B, C, and D can cause chronic hepatitis. So again, A and E are acute, B, C, D are chronic. And maybe you can help you with that. Maybe you could think about like, oh, those are vowels versus those are consonants. Maybe you could think, well, A and E, those are the first and the last. B, C, D, those are the ones in the middle. Whatever helps for you. A and E are acute. Acute starts with an A, it's a vowel. All those are vowels, whatever. B, C, D are chronic. Chronic starts with a C, which is a consonant. Whatever works for you. High yield point is that the hepatocellular damage from hepatitis is due to T cell mediated apoptosis, not direct viral cytopathicity. Same goes for the general hepatic inflammation. Choose T cell response, not direct viral effect. Hepatitis in general classically has ALT greater than AST, where the numbers can be in the hundreds to thousands, but I've seen plenty of variability on MBME questions, which is why I don't consider this a foundational point. Hep A. The answer for acute hepatitis in the United States most of the time. The question might say that the patient had a recent travel to Mexico. Fecal oral only causes acute hepatitis. IgM against Hep A means acute infection. IgG against Hep A means the patient has cleared infection because there is no chronic Hep A. USMLE wants you to know Hep A vaccine is indicated for IV drug users and MSM. When they say MSM, they mean men who have sex with men. Okay? They say men who have sex with men. It's like, I think there's a word for that. I think there's a few words we have for that. Like MSM, like in like mainstream media. So is that like MSNBC, Fox, CNN? No, something different. No, same. Different meaning. There's this 2CK NBME question where they just mentioned otherwise healthy MSM. Otherwise, I don't know. I don't think you can really call that healthy. I mean, if we're going to be honest with ourselves, given the organs involved in it, I think we can say I would not characterize that as healthy. It's not supposed to go there, okay? Listen. An answer is Hep A vaccination. So they say Hep A vaccination in that case. But they say that Hep A vaccine is indicated for both IV drug users and MSM. Sort of like saying healthy drug users, healthy heroin addicts. It's like, I mean, there's people who clean the needle, but like, no, there's people who try to make sure that the needle's not whatever, but like the behavior is not healthy. Okay, the thing itself is a problem. It just so happens that it has also secondary temporal consequences. So, Hep B. Mandatory stuff for USMLE is the serology I discussed below. Most common hepatitis infection in the world. Okay, they say worldwide. Okay, USMLE likes China for hepatitis B, Hep B. Just a pattern I've noticed due to significantly increased unvaccinated population. In the United States, Hep C is most common. So Hep B for China, Hep C for the United States. Parenteral can be acute or chronic, transmitted vertically from mother to neonate sex via drugs. Neonate sex via drugs or blood exposure. Presents in all body fluids, including breast milk. Serology, very high yield. Surface antigen, patient currently has Hep B. Surface antibody, patient is immune to Hep B. Core antibody, patient has Hep B now or did in the past. Core antibody IgM, patient has acute infection. Core antibody IgG, patient has a chronic Hep B or cleared Hep B. So positive surface antibody / negative core antibody means immune, vaccinated against Hep B. Positive surface antibody plus positive core antibody equals immune, history of Hep B, and it cleared it. Yeah, that's an important thing, is that you will only have the one surface antigen for the vaccine. You will not have the core antibody for the vaccine. So if you have both, it probably means you had an infection in the past. But if you only have the surface antibody, that means you were vaccinated. Negative surface antibody and negative core antibody means not immune, susceptible. Not immune / susceptible, need to vaccinate. Negative surface antigen and negative surface antibody plus core antibody IgM, window period. Okay, so that's like a window period during the infection sort of process, you could say. Hep B, vaccination against Hep B is at birth, 2 months and 6 months, no longer 4 months. Only give Hep B IVIG to neonate if the mom is confirmed positive. A 2CK NBME question gives mother status as unknown when the child is born. The answer would be give Hep B vaccine now, plus only give IVIG if the mother is positive. If the patient has a history of completed Hep B vaccination but has titers that show susceptibility, the answer is just give more vaccine. Sometimes people's immunity wanes. Only a susceptible patient is exposed to Hep B and the immune system attempts to clear it. Sometimes surface antigen will decline to the point that it is no longer detectable, but at the same time, the surface antibody might not be high enough / at detectable levels yet. This is called the window period, where both the surface antigen and antibody are negative, so it can appear as though the patient doesn't have an infection. However, core antibody IgM will be positive. So the key point is that 1, you know that the double negative surface antibody antigen combo is seen on the window period, and 2, the core antibody IgM is most reliable during the window period. USMLE doesn't care about Hep B farm, like entecavir or tenofovir, waste of time. Okay. You could be aware that the interferon alpha could be used for Hep B. You know, I've been doing obviously a lot of the first 2 years of medical stuff, and they have a lot of focus on these drugs and mechanism of action and so forth, that kind of stuff. And I guess they have a lot more of a clinical focus in these coming 2 years, I guess you could say, where they don't have so much focus on how does a drug work in terms of its biomolecular qualities, you know, whatever, its mechanism. They're more concerned about how do you apply it. Hep C. Hepatitis C. Hepatocellular damage is due to T cell / death is due to T cell mediated apoptosis, not direct viral cytopathicity. I already mentioned this at the top of the chart, and this applies to the other HEPs as well, but I reinforce this as what I'd still say is the highest yield point for Hep C on USMLE. Parenteral can be acute or chronic, transmitted almost exclusively from the IV / drug / blood exposure, not present in breast milk and non-sanguineous body fluids, in contrast to Hep B. In contrast to Hep B, Hep C is not considered sexually transmitted. Large longitudinal study of couples with one Hep C positive partner showed sexual transmission almost nil, possibly due to the menses exposure. If you're forced to choose on NBME, however, still informed that the abstinence or barrier contraception minimizes risk. No vaccine. I do not. I'm just gonna say, I disavow contraception, but yeah. I mean, it is possible that it can cause that. Anyway, no vaccine due to significantly elevated antigenic variation. That is to say, greater than 7 genotypes and 80 subtypes of Hep C exist. IgM against Hep C means acute infection. IgG against Hep C usually means chronic Hep C. Many drugs can be used to treat. USMLE does not care. What you could be aware of is the pegylated interferon alpha. Hep D requires hepatitis B in order to infect, which can be due to co-infection happening at the same time, or superinfection occurs later in someone who already has Hep B. If USMLE asks how to prevent Hep D infection? Answer equals vaccination against hepatitis B. There is no vaccine against Hep D. Apparently, Hep B antigen forms the envelope for Hep D, that is to say, forms a circle around the Hep D. Hep E causes fulminant hepatitis / significantly elevated risk for death in pregnant women. That's important to know. Same as with Hep A, only causes acute hepatitis. Seen more in Asia, for example, Tibet, but USMLE says Mexico plus pregnant woman plus fast death from hepatitis. You won't have to use your head and know it's Hep E and not Hep A. Other high-yield hepatitis causes. NASH, N-A-S-H. N-A-S-H. Answer on USMLE for the liver condition in an overweight patient with normal labs. Non-alcoholic steatohepatitis. Underrated diagnosis in that students have no idea no idea about it, but it shows up on both steps. Higher yield on 2-CKIM. Patient will have metabolic syndrome, that is to say, elevated BMI plus elevated lipids, plus either mild transaminitis or completely normal labs. I'd say 50% of questions will have ALT and AST a very tiny bit elevated. The other 50% of questions will give you completely normal labs where you will say, oh my gosh. For example, they'll give you a 40-year-old patient with BMI of 35 who comes in for routine health maintenance exam who has no complaints, plus lab studies are all completely normal, and the answer is just fatty liver or non-alcoholic steatohepatitis. Student says, wait, but the labs are completely normal, though. Exactly, there's nothing wrong, but it's assumed most overweight people have some degree of fatty liver. The condition starts out with completely normal labs, then progresses to a very mild transaminitis. Over time, LFTs can worsen, and really it can cause cirrhosis and carcinoma. Theoretical treatment is just hit the treadmill more and stop eating your dumb fast food. Okay, so NASH, though, what does that actually stand for? Let me look that up briefly. NASH, fatty liver. So NASH or MASH is called, they call it MASH now. MASH. Non-alcoholic steatohepatitis. Which I don't know, why is it called MASH? What's the other one mean? Non-alcoholic steatohepatitis, okay. Well, what does MASH mean? MASH means metabolic dysfunction associated with steatohepatitis. So they're basically saying it's a metabolic form of hepatitis. Non-alcoholic related. Let's go continue. Alcoholic hepatitis. Classically, AST is higher than ALT. They're both elevated, by the way, but AST is higher than the ALT. The ratio, and that's very distinct because the other kinds of hepatitis infections will have the ALT be higher than AST. So that's an important thing to be aware of. Alcoholic will have AST as higher. The ratio need not be 2-to-1. I've seen variations in NBME forms where they can be very mild transaminitis. Both AST and ALT are less than 100, with AST only slightly higher than ALT. And the vignette is hyper easy. They'll say something like AST is 400 and ALT is 200. Both should be normally less than 50. Causes steatosis, fatty liver. USMLE wants you to know that Mallory-Hyland is seen on biopsy. You don't need to know the image, just this factoid. Mallory-Hyland for alcohol. Acetaminophen hepatitis. Acetaminophen overdose, most important for USMLE, and acetylcysteine is antidote. That's important to know. Breakdown of acetaminophen produces a metabolite called NAPQI, that depletes reduced glutathione. The latter normally mops up free radicals / prevents oxidation. Patient will overdose on acetaminophen and be asymptomatic for 24 to 28 hours. Then will proceed to get ALT and AST in the tens of thousands, plus require liver transplant or death. N-acetylcysteine regenerates reduced glutathione. Memorize that. Oxidized glutathione has disulfide bond, SS. Reduced glutathione has thiol, SH. Activated charcoal should apparently be administered to patients who present very acutely after massive ingestion, as this can decrease the acetaminophen absorption. But I've never seen this on MBME. It tends to be more Q-bank, that's gotcha style this way. I've only seen N-acetylcysteine assessed across NBMEs. Okay. Also, when they say 24 to 28 hours, I would assume that's 24 to 48 hours, but maybe I'm wrong. How long can people be asymptomatic for acetaminophen overdose? I'm looking it up right now. They say 24 to 48 hours. So I would assume in this case that they accidentally put 2 instead of a 4. So it's 24 to 48 hours for how long they could be asymptomatic. Which is a lot of time, if you think about it. You take, let's say somebody's trying to end their life or something like that. So they take a lot of acetaminophen. And then they're just, waiting for, you wake up the next day. Yeah, nothing's happened yet. It's kind of a weird one. Of course, it's a really nasty way to die, but, It's hard to think of a way that to die that wouldn't be nasty, if you think about it, to be fair. So, anyway, so if you see something like that, just be aware of this, the antidote for that. Other drugs. I'd say some important drugs that can cause transaminitis are statins and fibrates, methotrexate, lithium, valproic acid, propylthiouracil. Mild transaminitis is normal and expected with these agents. The answer is you do not need to decrease the dose. Okay. For statins, myopathy is more common than toxic hepatitis on MBME. Myopathy is more common. Now we have some OBGYN related hepatic issues. HELP syndrome, HELLP. HELP syndrome, hemolysis, elevated liver enzymes, low platelet count, can occur as part of a severe preeclampsia, hypertension plus proteinuria after 20 weeks of pregnancy. Vignette will be pregnant women greater than 20 weeks of pregnancy where you see the platelets and hemoglobin are low and LFTs are up, not complicated. Highest yield point for USMLE is you get schistocytes on blood smear. USMLE is obsessed with this. Causes of schistocytes on USMLE is HELP syndrome, hemolytic uremic syndrome, what is that, thrombocytic. What does TTP stand for again? Purpura? Something purpura? TTP, purpura. It stands for thrombotic thrombocytopenic purpura. So let's go back into this. So hemolytic uremic syndrome, thrombotic thrombocytic purpura. Oh, now I forgot what DIC stands for. DIC, TTP. So DIC stands for disseminated intravascular coagulation. Okay, so I'm just trying to remember these names, okay? So causes of schistocytes and USMLE equals HELP syndrome, HUS or hemolytic uremic syndrome, TTP, which is thrombotic thrombocytic purpura, or DIC, disseminated intravascular coagulation, and mechanical heart valves. If you're about to trip out, don't worry. I talk about these conditions in the high-yield heme PDF. Intrahepatic cholestasis of pregnancy. It's on the USMLE for women in the 3rd trimester who gets itchy palms and soles and elevated serum bile acids. Cause of 3rd trimester miscarriage. Treat with ursodeoxycholic acid, ursodiol. Fitzhugh-Curtis syndrome. A pelvic inflammatory disease, chlamydia or gonorrhea, that has extended to the liver capsule. So PID going to the liver capsule. The USMLE wants you to know that this causes fibrin deposition on the liver, and due to the inflammatory process, this is similar to post-surgical adhesions, where the inflammation leads to fibrin deposition. Heavy metal liver diseases. Hereditary hemochromatosis. Autosomal recessive, HFE gene, chromosome 6. Iron overload. Mechanism USMLE wants is increased intestinal iron absorption. Main iron regulation is via shutting off the intestinal absorption. This is impaired in hemochromatosis. Body has poor ability to excrete iron, otherwise there are minor losses via skin shedding. Since women excrete naturally via menses, presentation occurs earlier in men who clearly don't have the mechanism of excretion. Can present at, apparently people disagree on that front for some reason. But yeah, no, I agree. Well, that's interesting. That's a sort of an interesting sort of situation how the other kinds of biological factors are kind of interacting with this disease because, for women, they have an iron loss because of menses. And so, in a certain sense, it's masking an underlying pathology that's going on, while simultaneously, in the same way, it's kind of managing it, it's making it less problematic because they already have a way of removing iron from the body in a way that men just don't. Anyway, so men will present earlier because they do not have this mechanism that causes blood loss and therefore iron loss. So it can present as bronze diabetes, hyperpigmentation due to hemosiderin deposition in the skin, plus an elevated fasting sugars, iron deposition and tail of the pancreas. Miscellaneous other findings can be seen, like infertility, iron deposition in hypothalamus, anterior pituitary or gonads, cardiomyopathy or arthritis, pseudogout. Hereditary hemochromatosis, primary hyperparathyroidism, and hypothyroidism are three most important causes of pseudogout. So hemochromatosis, hereditary hemochromatosis, primary hyperparathyroidism, and hypothyroidism are the three most common causes of pseudogout. I used to only discuss the former two with students over the years, but the latter shows up on the new 2CK MBME exam where they mention chondrocalcinosis, calcium deposition in the cartilage. USMLE wants to know there is a elevated risk of hepatocellular carcinoma. There is an easy MBME question of hemochromatosis where they ask what patient is at increased risk for, and the answer is simply hepatocellular carcinoma. Diagnosed with ferritin greater than 300 mg over DL, transferrin saturation will also be clearly elevated. It is exceedingly rare that ferritin is greater than 300 in other conditions. However, this can occur in lymphoma and leukemia where the elevated ferritin is a poor prognostic marker in non-Hodgkin lymphoma. There is one MBME question on 2CK where the ferritin is 300, where it's not hemochromatosis, but USMLE won't play gotcha. Treat with serophlebotomy, not chelators. So, not chelators. So, phlebotomy is like, aren't they just removing the blood? I think it's literally kind of like bloodletting. You're just removing the blood from the body because you're just making way too much iron. So, chelators such as deferoxamine or deferocerox are for secondary hemochromatosis due to transfusional siderosis. That is to say, repeated blood transfusions that contain iron. For example, for beta thalassemia major, but for actual people who are making too much, who have hereditary hemochromatosis, it's a hereditary primary issue, not secondary to transfusions. It's primary and hereditary. That you want to use phlebotomy for, serial phlebotomy. What about Wilson's disease? Autosomal recessive, copper overload, inability to secrete copper into bile from the liver. Copper is normally excreted from the body via secretion into bile. Elevated urinary copper leads to increased urinary copper plus decreased serum ceruloplasmin and copper binding protein in the blood. In the case of copper overload, body tries to minimize the amount carried in blood. Buzzy/pass level detail is Kaiser-Fleischer rings, which is copper deposited in the cornea of the eye. Vignette can give you what sounds like Wilson's disease, and then they'll say slit lamp exam. And then the answer is slit lamp exam. Okay, so slit lamp exam can cause elevated LFTs with cirrhosis and Parkinsonism. Copper deposits in basal ganglia, especially in the putamen. Parkinsonism is in a young patient, Wilson's until proven otherwise. In an old patient, Parkinsonism equals Parkinson's disease, normal pressure hydrocephalus, Lewy body dementia, or progressive supranuclear palsy. So that's important to note that it's going to be different between the young and the old. So the old, you would say, oh, it's Parkinson's disease. Or maybe it's hydrocephalus, normal pressure. Or maybe it's Lewy body dementia. Or maybe it's progressive supranuclear palsy, something like that. But for young people, it's like, okay, this is clearly something like Wilson's disease. It's something out of the norm. Treat with copper chelator penicillamine. Bowel ischemia. Ischemic colitis. Patient with cardiovascular disease, CVD, plus blood in the stool. caused by bleeding at ischemic ulcers at watershed areas in the colon, that is to say, the splenic flexure and the rectosigmoid junction. Can occur randomly or due to inciting event like recent abdominal aortic aneurysm surgery. Diagnose with colonoscopy to visualize the ischemic ulcers. Chronic mesenteric ischemia. Patient with cardiovascular disease plus abdominal pain 1 to 2 hours after eating meals. Caused by atherosclerosis of the superior mesenteric artery or the inferior mesenteric artery, leading to consuming food with increased oxygen demand to the bowel, leading to angina of bowel. The timing of this pain in relation to meals sounds like duodenal ulcers. However, instead of the vignette being a 29-year-old dude from Indonesia with a H. pylori, it will be a 69-year-old dude with a history of coronary artery bypass grafting, intermittent claudication, hypertension, and diabetes. The next best step is mesenteric angiography on USMLE. So, different kind of patient profile. Acute mesenteric ischemia. It presents three different ways on USMLE. Severe abdominal pain in patient with a AF. Was that like AFib? Severe abdominal pain in patient with AFib. Left atrial mural thrombus launches off to SMA or IMA. The severe abdominal pain in patients just cardioverted or defibrillated can cause left atrial thrombus off to the superior mesenteric artery or inferior mesenteric artery. There's a question on 2CK form where this is the case, where they don't mention the AFib in the stem. Severe abdominal pain in the patient with a history of a chronic mesenteric ischemia, i.e. acute on chronic, atheroma with SMA or IMA ruptures, effectively causing an MI of the bowel. USMLE wants mesenteric angiography as the next best step. Laparotomy is also on the NBME form. I've never seen medications or endotorectomy as answers. Okay, so I'm going to go take a brief break and I come back to you. We're on page 140 and we will be finished on page 148. Okay, let us continue. We're on page 140. Let's go to GI thromboses. Mesenteric vein thrombosis. The splenic vein and superior mesenteric vein, SMV, merge to form the portal vein. The inferior mesenteric vein, IMV, goes to the SMV. Cirrhosis goes to lead to increased portal venous pressure, which causes an increase in SMV and IMA pressure, leading to stasis. In addition, any malignancy a patient might have leads to hypercoagulable state. NBME question gives patient with cirrhosis and lung cancer who have abdominal pain plus dark mottled small bowel or surgical examination. The answer should be mesenteric venous thrombosis. Students ask why. I say, well, there's an elevated mesenteric venous pressure from the cirrhosis plus a hypercoagulable state from the malignancy. Splenic vein thrombosis. Risk factors are the same as above. As I discussed earlier, USMLE wants you to know splenic vein thrombosis is a cause of esophageal varices due to the collateral development which the left gastric vein, which drains the esophageal veins. So if an increased left gastric venous pressure, then an increased esophageal venous pressure. Then you will have an elevated esophageal venous pressure. Okay. USMLE wants you to know that the short gastric veins feed into the splenic vein. So if you have an elevated splenic venous or portal venous pressure, then the short gastric veins also have an elevated pressure. Budd-Chiari syndrome. Hepatic vein thrombosis. The hepatic vein drains the liver, caused by polycythemia vera and pregnancy. So polycythemia vera and pregnancy is what causes Budd-Chiari syndrome. Triad would be abdominal pain, ascites, and hepatomegaly. Portal vein thrombosis. Caused by portal venous stasis from cirrhosis, portal vein enters the liver. What about appendicitis? Triad of right lower quadrant pain, fever, and vomiting, Murphy's triad. Pain starts at epigastrium, visceral pain, and migrates toward the right lower quadrant, parietal pain. USMLE will ask why there is movement of the pain. The answer would be the inflammation of the parietal peritoneum. So basically, it's initially located in one location, which is at the epigastrium because it's kind of like internal to the appendix itself is in pain. And then there's like a leakage of fluid that causes the parietal peritoneum to be inflamed, and that causes the right lower quadrant pain. Pain at McBurney's point 1/3 of the way from the anterior superior iliac spine to the umbilicus, plus Rovsing sign, pain felt in right lower quadrant upon palpation in the left lower quadrant. USMLE wants you to know that appendicitis pain can cause right upper quadrant in pregnancy due to the displacement of bowel and a shift in appendiceal location. What they will do is tell you pregnant women in third trimester has a right upper quadrant pain. Right upper quadrant in pregnancy. So right upper quadrant, okay. But what they'll tell you is that a pregnant woman, What they'll tell you is that a pregnant woman in the third trimester of pregnancy has right upper quadrant pain, fever, and vomiting, plus a negative abdominal ultrasound, meaning not cholecystitis. Answer would be appendicitis. Again, despite being in the right upper quadrant, because she's pregnant, there's a displacement. Inflammatory mass and fecalith in the cecum is a phrase used on 2CK NBME form to describe appendicitis. Again, they won't necessarily tell you up front what is it. It's appendicitis. It might say inflammatory mass and fecalith in the cecum. Right. You know, they might not tell you, oh, what language is he speaking? And they don't tell you, oh, he's speaking Gallego. They'll tell you, oh, he speaks the language which pertains to the area of Spain that's called Galicia. It's like, okay, well, you mean Gallego, right? It's like, well, yes, right. It's sort of this roundabout way of phrasing the thing we're talking about. Anyways, a phrase used on 2CK NBME form to describe appendicitis. Diagnosis is done via the ultrasound first and sometimes the CT. However, I have not seen USMLE assess either of these, likely because their utility is debated. What I have seen is laparoscopic removal in the stable patient. USMLE will give you ethics/consent question where they can say a patient has operation performed for ovarian procedure, but it is seen that she has an acutely inflamed appendix, so the answer would be removed due to necessity of medical emergency. However, if the scenario is reversed, and while performing an appendectomy, the surgeon notices a suspicious lesion on, for example, one of the ovaries, the answer is do not biopsy. Consent must be obtained for all non-emergencies. High-yield colorectal proctocolonic diagnoses. Angiodysplasias, tortuous superficial vessels in the colonic wall that cause painless bleeding per rectum in elderly. Classically associated with aortic stenosis, Hyde syndrome, possibly related to the pressure back up to the colon. NBME question gives older guy arguing with his wife, plus gets chest pain and bleeding per rectum. Even though colonoscopy is used for diagnosis, they say that in this question, the colonoscopy is negative, likely to tell you it's not cancer causing the bleeding. Diverticulosis, mere presence of diverticula in the colon, greater than 50% of people over the age of 60 in the United States. Elevated straining throughout life leads to herniation of mucosa plus submucosa through the muscularis propria of the colonic wall. Usually asymptomatic but can bleed, diverticular bleed is most common cause of painless bleeding per rectum in elderly, followed by colorectal cancer, followed by angiodysplasia. Can cause colovesical fistula on new 2CK NBME, where a passageway between the colon and the bladder forms, leading to a UTI and mixed flora in the urine. Do not confuse with diverticulitis, which is when a diverticulum becomes inflamed. Diverticulitis. Left lower quadrant pain plus fever in patients over the age of 60. One of the highest yield diagnoses in USMLE. Inflamed diverticulum, usually in the sigmoid colon. CT of the abdomen with contrast is how to diagnose. Do not scope acutely, as this can cause perforation. After a patient is treated with antibiotics, a colonoscopy should be scheduled weeks to months later to rule out malignancy, but once again, never scope acutely. Perforated diverticulitis can require colectomy. Sigmoid volvulus. Patients over the age of 75 plus 2 to 3 days of constipation plus abdominal pain. Rotation around its mesentery causes a dilation of the sigmoid colon. Answer on the NBME as what is most likely to be seen in the patient. The abdominal X-ray is used to diagnose, which shows a coffee bean sign, which is one of the highest yield radiographic images on USMLE. Treatment on NBME is sigmoidoscopy guided insertion of the rectal tube. Fecal impaction. Patient over 70 plus chronic constipation plus hard stool palpated in the rectal vault can sometimes cause fecal incontinence and paradoxical overflow diarrhea, leading to encopresis, that is to say, word for defecating your pants. Listen, we're keeping it PG here, okay? We're trying to. Idiopathic but exacerbated by opioids. Treatment is with enema and laxatives. Okay, so patient 70 plus, chronic constipation, so fecal incontinence, and then paradoxical overflow diarrhea. That's okay. So that's fecal impaction. Hemorrhoids, bleeding per rectum that will be described as a bloody on the toilet paper, or blood that drips into the toilet bowl. Hemorrhoids are technically normal vascular structures within the anal canal that facilitate cushion the passage of stool. Bleeding time from the internal hemorrhoids is painless. These are above the pectinate line in the anal canal. Bleeding time from external hemorrhoids is painful. These are below the pectinate line. So again, below, painful. Above, you can't feel it. Pregnancy and cirrhosis are risk factors. It doesn't mean that it's not happening, right? You could bleed from internal or external hemorrhoids above or below the pectinate line, but it's only the lower ones that you're going to feel pain below it. 2CK NBME wants rectal exam followed by endoscopy for diagnosis. Hemorrhoids often self-resolve and can be managed conservatively with sitz bath, NSAIDs, and increase in dietary fiber. However, if USMLE forces you to choose between surgical management for more severe cases, the answer is rubber band ligation. Anal fissure. Young adult who has painful bowel movements plus or minus blood in the stool. The key detail is they refuse the rectal exam because the pain is so bad. For whatever reason, they can also say that there is an associated skin tag. I've seen that more than once where the students say, what's the skin tag? No clue. Mechanism can be increased anal sphincter tone. Treatment on the 2CK surgery is sitz bath. If the USMLE forces you to choose a medication, topical nitrates or diltiazem is used. Pilonidal cyst or abscess. Pilonidal cyst or abscess. Answer on the USMLE for cystic mass as the superior aspect of the gluteal cleft contains hair, often caused by ingrown hairs. Perianal abscess. Yeah, these do not sound pleasant, let me tell you that. Perianal abscess. Answer on the USMLE for painful erythematous mass near the anal verge. Increased risk in Crohn's disease and diabetes. Treatment would be on 2CK surgery, incision, and drainage. Anal malignancy. 2CK surgery question gives a cancer at the anal verge, plus asks for the next best step in management. The answer should be colonoscopy. Excision is wrong answer. Colonoscopy. Presumably the scoping is done to first investigate the extent of the disease, as that might alter the management. So go for colonoscopy as the first step. What about this next thing called high-yield bacterial infections? This is going to be going to micro, I guess. So high-yield GI bacterial infections. Gram-negative rods first. ETEC. Enterotoxigenic E. coli causes traveler's diarrhea. Will present as a brown/green diarrhea in a person who's gone to Mexico or Middle East classically. EHEC, EHEC, enterohemorrhagic E. coli, causes bloody diarrhea 1 to 3 days after consumption of beef. Produces a Shiga-like toxin, that's important, Shiga-like toxin with very similar mechanism, which can cause hemolytic uremic syndrome, HUS, triad of renal dysfunction, schistocytosis, and thrombocytopenia. Shigella, bloody diarrhea 1 to 3 days after the consumption of beef, can also cause hemolytic uremic syndrome via the Shiga toxin. Salmonella, food poisoning is caused by Salmonella typhimurium and Salmonella enteritidis. The nomenclature has changed with time, but those names are acceptable. Bloody diarrhea 1 to 3 days after the infection from consuming poultry or following exposure to eggs or reptiles, for example, turtles or lizards. New MBME question mentions bloody diarrhea in someone with a pet lizard. Salmonella typhi causes typhoid fever, which will be rose spots on the abdomen in the patient who's prostrated, that is to say, lying down in pain, can be either diarrhea or constipation. The reservoir for Salmonella typhi is humans, not chickens or reptiles. What about Vibrio cholera? So Vibrio cholera presents as liters and liters of rice water stool in someone who went traveling to Mexico, for example, Mexico. The way you can differentiate this from ETEC, traveler's diarrhea, is that the cholera is notably profusely high volume. Acquired fecal oral, that is to say, for example, fecal contaminated food or water. Both ETEC and cholera vignettes can tell you the patient has 8 to 12 stools daily, so it's not the number of stools that matters, it's the emphasis on volume. Cholera causes death via severe dehydration and electrolyte disturbance. The treatment would be oral rehydration on USMLE. If the patient has a low BP or altered mental status, i.e. confusion or coma, IV hydration is done. Vibrio perihemolyticus doesn't cause profuse watery diarrhea the same way that cholera does. I've seen this organism S on MBME vignette where the patient ate sushi, can be acquired from sushi and shellfish, but it's not going to have the same presentation necessarily. Vibrio vonificus causes severe sepsis in half of patients. This is asked on offline MBME 19 where the dude went running on a beach and got sepsis with no mention of consumption of food, but it's apparently acquired from shellfish. But remember, cholera is the top dog. Think about profuse high volume diarrhea, and treatment would be oral hydration. And if severe BP issues or mental status problems, go for IV hydration. Yersinia enterocolitica. So causes bloody diarrhea plus either appendicitis-like, i.e. right lower quadrant, or pain or arthritis. The right lower quadrant pain is from the mesenteric adenitis or terminal ileitis. Toxin has some MOA as ETEC, heat label toxin, that is to say, for example, elevated cyclic GMP. Campylobacter jejuni, bloody diarrhea plus 1 to 3 days after the consumption of poultry, can be caused by Guillain-Barré syndrome, ascending paralysis plus a decrease in tendon reflexes plus an albinocytologic dissociation in the CSF. Treatment would be with IVIG, plasmapheresis. Grows best at high temperatures, 42 degrees. Bacillus cereus. Watery diarrhea and or vomiting in patient who's consumed reheated or fried rice. The process of heating or reheating causes germination of spores. It can also cause eye infections, weird but unussimile. They'll say a patient who has had eye surgery now has an infection caused by gram-positive rod. That will be only gram-positive rod listed. Bacillus cereus. But again, Bacillus cereus, think about reheated fried rice or something like that. Causing watery diarrhea or vomiting. The way I remember is like cereus has the word R and C in it. So I think about rice, cereus, rice. And so I started thinking about that, reheated rice or fried rice. Clostridium perfringens, or perfringens or something like that. Watery/secretory diarrhea followed by consumption of poultry causes gas. That's hard to tell. Oh, wow. Somebody was eating poultry and they got sick. It's like, okay. But Clostridium perfringens, or perfringens, causes gas gangrene, CO2 gas, due to the production of alpha-toxin phospholipase, presents as a black skin crepitus. Can also cause emphysematous, cholecystitis, air in the gallbladder wall. Clostridium difficile. So, by the way, Clostridium perfringens is where you get gangrene from, by the way. Gas gangrene. But in this context, we're talking about the sort of bowel effects it can have if you consume it, if you get it in your bowels because you ate something that was not a good idea to eat, that kind of thing. So a different way you can get presentation. Clostridium difficile, diarrhea, pseudomembranous colitis, 7 to 10 days after the commencing of oral antibiotics. Antibiotics kill off normal bowel flora, allowing C. difficile to overgrow. C. difficile is not normal flora. However, it is acquired via consumption of spores, can be watery or bloody diarrhea on MBME, can cause left lower quadrant cramping, not right lower quadrant as with Yersinia. There is an NBME question where they say the 28-year-old with a left lower quadrant cramping and bloody diarrhea 7 days after starting oral antibiotics. The answer would be C. diff. Wrong answer would be Yersinia. USMLE doesn't care about which antibiotics cause it. It can be any. Diagnosed with the stool AB toxin test, stool culture is wrong answer. Stool AB toxin test, not stool culture. You treat with the oral vancomycin. Vancomycin has a poor oral bioavailability, so it usually is given IV for things like endocarditis and meningitis. But for C. diff infection, that's a good thing because we want it to stay within the GI tract. Other fancy antibiotics like fidaxomicin or rifaximin, etc., I've seen on the NBME. I've never seen on the NBME more things around dumb factoids. Okay. Anyway, gram-positive cocci. Gram-positive cocci, Staph aureus. Staph aureus preformed heat labile toxin is acquired for two main sources on NBME. Various meats sitting under a heat lamp / out for long periods of time, for example at a buffet. 2. Dairy products like creams, custards, potato salad. Notably causes vomiting 1 to 6 hours after consumption. This is notable as the symptoms occur rather quickly. Diarrhea, both watery and bloody, can occur, but is not mandatory. The main crux is the vomiting. Other GI bacteria. We have Trophorima Whippley, causes Whipple's disease. a GI malabsorptive syndrome where the patient can also get arthritis and renal and cardiac disease. 100% of questions will say PAS positive macrophages in the lamina propria. New highly pedantic question on the 2CK NBME 10 wants ceftriaxone plus daily TMP slash SMX, which is Bactrim. TMP SMX says trimethoprim sulfamethoxazole, which is Bactrim. So it says here ceftriaxone plus daily TMP SMX for 1 year as a treatment. Organism isn't even high yield, no idea why they care. Topical sprue causes flattening of the villi similar to celiac, but considered an infective bacterial in origin. Literature says exactly etiology is not certain. Answer on USMLE for patient living in top tropical area with unknown malabsorptive disease where you can easily eliminate the other answers. The treatment for this tropical sprue would be tetracycline. And then go take a brief break again. Okay, we're back. High-yield GI viral infections. Rotavirus, most common cause of watery diarrhea in unvaccinated children less than 5 years of age. Vaccine normally given orally at 2, 4, and 6 months of age. Norwalk virus, also called Norwalk virus, also norovirus, which is a calicivirus. Most common cause of watery diarrhea in adults and in rotavirus vaccinated children. Cruise ships and business conferences are buzzy places to acquire fecal oral. Basically, it's fecal oral is how you get it. Basically, at any place with a high density of people. But cruises is where they want to say in the test questions a lot of times. If the question says a young child plus family all have watery diarrhea, the answer is Norwalk virus, not rotavirus, since only the young children would get rotavirus, not the family also. Herpes virus, HSV1 and 2, causes herpes esophagitis, leading to adenophagia plus punched out ulcers in esophagus. Cytomegalovirus, CMV. CMV esophagitis, adenophagia plus linear confluent ulcers in esophagus. CMV colitis, bleeding per rectum in AIDS patient with CD4 count less than 50. CMV retinitis, blurry vision in HIV or immunosuppressed patient. Most common organism transmitted via blood transfusions and organ transplants. USMLEs like intranuclear inclusions or intranuclear inclusion bodies for CMV. This refers to the owl's eyes that can be seen in histo. Or on histo, I should say. High-yield GI protozoal infections. A protozoan is a unicellular eukaryote. EKG shows an Entamoeba histolytica, Cryptosporidium parvum, ECG, Entamoeba histolytica, Cryptosporidium parvum, and Giardia lamblia are the GI protozoa that are acquired via cysts in water. That is, they are waterborne. If the waterborne and fecal oral are both listed as answers, USMLE wants waterborne as the means of acquisition. Waterborne for these three. Entamoeba histolytica, Cryptosporidium parvum, and Giardia lamblia. So Entamoeba histolytica, bloody diarrhea in person who went to Mexico, can cause flask-shaped ulcers in the small bowel and liver abscess. Demonstrates erythrophagocytosis where the RBCs can be seen within it on LM. Treat with metronidazole. Iodoquinol kills the intraluminal parasite. What about Cryptosporidium parvum? Watery diarrhea for Cryptosporidium parvum. Watery diarrhea in person who went to Mexico appears on an acid-fast cyst, same stain as TB. Self-limiting in immunocompetent persons, treatment would be supportive care. Chronic diarrhea and HIV, treatment would be nitazoxanide. And one of the things I want to say right now is that for the way that I remember histolytica is bloody is that you think about something that's lytic, histolytic, it's lytic. It's breaking things down, it's tearing things up, it's lysing it. And so you can think, oh, what happens if you tear something up? It bleeds, right? And so that's the kind of way I remember histolytica being bloody. What about Giardia lamblia? Steatorrhea in person who went to Mexico. Steatorrhea, bloating plus extremely foul-smelling stools that floats. The steatorrhea is due to a Giardia causing malabsorptive diarrhea. There is one MBME question for Giardia where they say foul-smelling, watery diarrhea with bloating, which is audacious since 9 times out of 10 is not described as watery, but the bloating and foul-smelling are consistent with steatorrhea in this context. Just letting you know it exists. They might kind of throw you off of the watery part, but really it's more that it's a steatorrhea. It's a foul-smelling, fatty diarrhea. Acquired via freshwater lakes, scuba diving, there is a Giardia MBME. You just know that it's not bloody. Okay? It's a fatty stool, not a bloody stool. Fatty stool. Acquired via freshwater lakes / scuba diving, there is a Giardia MBME question where they say a woman goes scuba diving in Mexico and then gets foul-smelling stools with bloating. Student says, wait, but I thought Giardia was freshwater. If she went scuba diving in the ocean, then how is this Giardia? People can go scuba diving in freshwater lakes too, bro. Don't know what to tell you. Okay. Yeah, just be aware of that. Flagellated protozoan USMLE wants you to know that the images for this, both the cyst as well as the flagellated trophozoite. So there you go. That's the cyst form of Giardia, not dramatic. And here's the trophozoite form for Giardia. It looks kind of like that. Don't know what else to say. It's interesting. Look into it. How do you treat Giardia? Metronidazole. So we're on page 146 now. Let us proceed forth. High-yield GI parasitic helminth infections. USMLE wants you to know the routes of acquisition for the nematodes, that is to say, ingested or through feet, etc. You do not need to obsess over exactly which anti-helminthic agent treats which organism. Waste of time. What USMLE wants you to know is that the big picture concept that bendazoles, like mebendazole, and parentel pamoate are the two agents that treat nematodes primarily. Bendazole's microtubules, tubulin, and parentel pamoate cause helminth paralysis. Praziquantel is used for cestodes and trematodes. It causes helminth paralysis. Albendazole is the odd one out that is used for neurocysticercosis, tinea solium cestode. USMLE does not care about diethylcarbamazine. Nematodes, roundworms. So we really are going into sort of the micro stuff, I guess. So that's something to be aware of, I suppose. So nematodes, roundworms. Ascaris lumbricoides. Ingested giant roundworm causes intestinal obstruction, ascariasis. Enterobius vermicularis, ingested, causes perianal itching / positive tape test in children, enterobiasis. Angiostrongylus, ingested by eating raw slugs / snails, causes eosinophilic meningitis. You might ask yourself, well, who eats raw slugs or snails? The French, at least the snail part. Escargot. Anyway, well, I don't know. Remember, it has to be raw slugs or snails. Raw slugs or snails. Trichinella spiralis, ingested by eating pork / bear meat. Again, who's eating bear meat? That's a great question. It causes triad of fever, periorbital edema, and myalgias, trichinosis. Pork is an important one for trichinosis, though. Beware of that. Strongyloides stercoralis, acquired through the soil / one's feet, causes intestinal obstruction plus pulmonary symptoms, apparently travels up to the lungs via the blood, then travels up to the respiratory tree into the esophagus where it is swallowed. Hookworms, acquired through the soil / one's feet, hookworms refer to Ankylostoma duodenale and Necatura americanus. I always remember that as being Adna, those two species, Ankylostoma duodenale and Necatura americanus, which are kind of conflated. Causes microcytic anemia / decrease in hemoglobin due to the suckling blood in GI tract. Next one is cestodes, or tapeworms. Diphyllobothrium latum. Fish tapeworm, nothing else you need to know. Okay. Tinea solium. Pork tapeworm caused by cysticercosis, muscle pain / cysts, plus neurocysticercosis, Swiss cheese appearance of the brain, or soap bubbles and ventricles. That does not sound pleasant, but tinea solium is like that. Echinococcus granulosus, aka hyatid worm, or dog tapeworm, causes hyatid cyst disease, acquired from dogs, clearly. Causes liver cysts. Only point you need to know is that you do not need to biopsy because this can cause anaphylaxis. Treatment would be surgically remove. So you do not biopsy because it can cause anaphylaxis. You treat it by surgically removing. What about trematodes or flukes? You have schistosoma, penetrates the skin when swimming, snail is host. Schistosoma mansoni or japonicum can cause portal hypertension, not high yield, but shows up once on the MBME, not to be confused with schistosoma hematobium, which causes a squamous cell carcinoma of the bladder. Different situation. So Mansoni japonica or more is a little bit different presentation, clinically. Paragonimus westermani, ingested from crab meat or crayfish, aka lung fluke, most common cause of hemoptysis in the world. Interesting. Lung fluke right here, Paragonimus westermani. Clonorchis sinensis, ingested from fish, causes cholangiocarcinoma. (147) GI Farm Basics for Internal Medicine. Proton pump inhibitors. Omeprazole, shut off proton pumps on parietal cells, leading to a decrease in acid secretion. Irreversible and non-competitive, more efficacious than H2 blockers, which are reversible and competitive. Choose PPIs over H2 blockers for treatment for most things, like GERD, ulcers, and H. pylori. Diagnosis of GERD is 2-week trial of proton pump inhibitors. PPIs cannot be given with sucralfate or azole antifungals on NBME. H2 blockers, cimetidine and ranitidine, not used often. PPIs are more efficacious. On 2CK Form has a 2-week trial of H2 blocker as a correct for diagnosis of GERD, but PPIs are not listed. As I said above, though, if you are forced between the two, between a PPI and an H2 blocker, the PPI is correct basically always. Cimetidine can cause gynecomastia and then inhibits P450. Metoclopramide. As discussed earlier, antiemetic plus prokinetic agent means increase in peristalsis, a D2 antagonist but also an antagonist of serotonin 5-HT3 and agonist of 5-HT4 receptors. The effects of the serotonin receptors increase the gut peristalsis. High yield use in USMLE is diabetic gastroparesis, that is to say, sounds like GERD, but the patient has severe diabetes, where the answer is metoclopramide, not proton pump inhibitor. Ondansetron, powerful antiemetic classically used for nausea and vomiting from chemoradiotherapy. What about erythromycin? Motilin receptor agonist that can be used for diabetic gastroparesis, unrelated to its antibiotic utility as a macrolide. Interesting. Misoprostol, PGE1 analog used for NSAID-induced ulcers after PPIs. NSAIDs decrease the prostaglandins, therefore misoprostol is the replenished prostaglandin. Prostaglandins decrease acid production and increase mucus and bicarb production and increase gastric mucosal blood flow. Magnesium, antacid, causes diarrhea. Aluminum, antacid, causes constipation. Aluminum amount of feces. Okay, so sure. Calcium, antacid, causes milk alkali syndrome, elevated calcium plus elevated bicarb plus urolithiasis. Bisphosphonates, for example, alendronate, and tetracyclines, that is to say doxycycline, cannot be taken with calcium or iron supplements, i.e. divalent cations, since the latter chelate the drugs and decrease the absorption / oral bioavailability. USMLE loves this. USMLE will give you, e.g. prostatitis treated with ciprofloxacin, plus lists all sorts of other medications the patient is on, as well as a calcium supplement, and then tell you the patient's condition isn't improving, plus ask why. The answer is calcium carbonate. Bismuth can be used as part of the H. pylori regimens but not first line. Sucralfate can be used to coat ulcers, forms a barrier to protect against acid and decrease pain, cannot be taken with PPIs. The latter decreases the ability of sulcralfate to crosslink / work correctly. 5 ASA compounds, mesalamine, sulfasalazine, NSAIDs used for IBD as discussed earlier. TNF alpha blockers, infliximab, adalimumab, and etanercept. USMLE likes these for IBD after 5 ASA compounds and steroids are attempted, after the fact. Infliximab and adalimumab are monoclonal antibodies against TNF alpha. Etanercept is a recombinant receptor that mops up the soluble TNF alpha. Octreotide, somatosine analog used for esophageal varices and treatment after banding, acts by decreasing the portal blood flow. Propranolol, beta blocker that can be used for esophageal varices prophylaxis, not treatment. Lactulose, used for treatment of hyperammonemia and cirrhosis. Carbohydrate that is metabolized by the gut bacteria into acidic substrates that trap ammonia as ammonium. The latter is then excreted. Ions aren't absorbed as easily. The answer on USMLE is acidification, NH4, for what lactulose causes in the gut. Neomycin used to treat hyperammonemia in cirrhosis. Antibiotic that kills ammonia-producing bacteria. Loperamide, mu-opioid receptor agonist used to treat diarrhea-predominant IBS. Opioids cause constipation, so this is a good thing in this case. So opioids cause constipation, so you can use loperamide as a way to treat diarrhea in IBS. Ezetimibe blocks cholesterol absorption in the small bowel. So if you have hyperlipidemia, you might have to consider that as a possible way to treat it or manage it or what have you. Cholestyramine, bile acid sequestrant, causes reduced enterohepatic circulation of bile acids at the terminal ileum, which leads to liver must now convert more cholesterol into bile acids in order to replenish them, which causes the liver pulls cholesterol out of the blood to accomplish this. Orlistat, pancreatic lipase inhibitor used for obesity, can cause steatorrhea. Nystatin, mouthwash used for oropharyngeal candidiasis. Fluconazole, used for candidal esophagitis. Acyclovir, HSV esophagitis, HSV-1-2 causes punched-out ulcers. Ganciclovir, CMV esophagitis and colitis, causes linear/confluent ulcers, same MOA as acyclovir. CAP, which is clarithromycin, amoxicillin, and a PPI, that's going to be for first-line treatment for H. pylori. If the patient has a positive urease breath test for 4 weeks, assume antibiotic resistance and switch out the CA and add tetracycline. Metronidazole. So they say switch out the clarithromycin and amoxicillin and add a tetracycline and metronidazole and bismuth and keep the PPI. What about vancomycin, Vanco, given orally to treat C. difficile? Metronidazole, anaerobes below the diaphragm is what you use it for. Used for diverticulitis in combo with fluoroquinolone, treatment for giardia plus entamoeba. Imipenem, carbapenem antibiotic that has fantastic penetration for pancreatitis. Mebendazole, used for most nematodes, that is to say Ascariasis, Enterobiasis, hookworms, etc. Albendazole, same as mebendazole, but whatever reason it's known as a preferred agent for neurocysticercosis, which is caused by a cestode, Taenia soleum. Parental pamoate, agent used against nematodes, shows up on an offline NBME as answer. Praziquantel, used for cestodes and trematodes. And that is the end of the gastroenterology section of the Mehlman Medical Internal Medicine PDF. And so this was the third installation, you could say the third live stream of this chapter. If you enjoyed this, cool, what have you, smash that like button, whatever you want to do in that regard. Comment, subscribe, whatever. And hopefully it was useful for you. Otherwise, have a great rest of your day. Thank you and goodbye.